Now this is a time for section B. First of all, question number 5. So sub question A and sub question 1 of question A. How will you investigate patient with hyperthyroidism? Why is TSH more sensitive than T4? So what you have to do? Thyroid function test. What is the in there in thyroid function test? Estimation of TSH, T3, T4. Then in case of hyperthyroidism, thyroid stimulating antibodies. Then imaging USG X-ray for seeing the enlargement of thyroid gland. Then radioiodine scan or checking the hyperactivity of the gland or the checking for the hyperactive nodules. Okay. Why is TSH more sensitive than T4? TSH is more sensitive than T4 because it has feedback control. T4 has a short half time, so it can be high sometimes, it can be low sometimes. But TSH and it also doesn't have negative feedback loop. TSH is in under negative feedback control, and small changes in T4 can regulate, what we say, give feedback to the pituitary and regulate the levels of TSH. So TSH is more sensitive than T4. Okay. So next question. What are the eye signs present in Graves' ophthalmopathy? How will you treat it? So what are the eye signs? Few people have written about the pathology which is occurring in the eye during Graves' ophthalmopathy. You don't have to write that. You have to write the signs which you will see, such as what you will see, that exophthalmos, then a lead lag, then a sunset sign. These are the various signs. We know it from surgery also and medicine also. How will you treat it? Simple. You have to use the lubricants for the eye cornea because the eye does not close properly. Then you can use the patch or the patch for closing the eyes over the eyelids. Then you can do surgery for removing the excess tissue or for correcting the exophthalmos. Okay. Then next, a 40-year-old female known case of bronchial asthma presented to OP with severe breathlessness, inability to speak, tightness of chest, bluish tint on lips. Then how will you manage the patient? What is the long-term management? So how will you manage the patient? What is the condition? It is a status asthmaticus. So what you have to do? You have to write there the patient is suffering from status asthmaticus or acute severe attack of bronchial asthma. So when you write that, then your treatment will make more sense. Okay. So don't worry. Okay. So there is a treatment chart. You have to write the treatment in terms of flow chart. What you will do? You will first start general investigation, take blood for investigations simultaneously and start the treatment immediately. So investigations, what you will do? Arterial blood gas, that is most important. Chest x-ray, there is no time for that. So ABG is most important. Then you can do CBC because checking hemoglobin and other things, but ABG is most important in this condition. Then management, what you will give? You will give beta-2 agonist first, salbutamol, terutolin by inhalational method. Whenever you are writing this thing, treatment of say any medical condition, especially in this case, bronchial asthma, you have to write the route of administration because in this case it becomes especially very important because it is acute severe condition and there are inhalational routes are more effective in the case of asthma or status asthmaticus. So you will do you will give beta 2 agonist. See, status asthmatics will not respond to the single inhalational drug. So you have to give all types of bronchodilator available to you. Which are the bronchodilator available to you? that to immediately acting beta 2 agonist, then anticholinergics, ipratropium bromide, tiotropium bromide, XL, and several others. They also in the by the inhalational method. Then third is methylxanthines, aminophylline, deriphyllin. What is the route? It is IV. Then you have to take care about slowly giving the drug because it can cause tachycardia severe, especially if there is some cardiac pathology underlying. And at the same time, you are giving beta 2 agonist and you are giving methylxanthines, so tachycardia can be very more. So cautiously, slowly. These are the bronchodilators which you have to give immediately, and these are the most effective. Then you have to go hydrocortisone 100 mg IV. Why? Because it will help to decrease the inflammation, and it will help in decreasing acute immune response, which is leading especially it can suppress the acute immune response, which is leading to the release of histamines and subsequent attack, bronchial asthma. So these are the main drugs which you have to give immediately. If this doesn't work, then you will go for the intubation. So what you have to do, you have to write sequentially. Give these beta 2 agonists, then the anticholinergics and methylxanthines, then steroids. And if still the patient doesn't respond, intubation. So make a treatment chart. What is long-term management? Depends on severity of disease. The patient is prone to the status asthmaticus, so probably his symptoms will not be controlled by a single drug which we prescribe generally, that is beta 2 agonist. So what we have to do, we have to give multi-drug treatment. If the symptoms are not controlled with a single drugs, first line of treatment is beta 2 agonist. If short acting or long acting, if there is a, we cannot use it continuously because there is a tachyphylaxis or what you say habituation, and there is decrease in response to the beta 2 agonist. So beta 2 agonist combined with anticholinergics and steroid. This is usually management for the long term bronchial asthma. And then we can add say methylxanthines orally, or steroids orally is not usually required, but we can add in severe cases. Okay, write about the next question. Write about the neurological complications of diabetes mellitus. How will you treat the case of diabetic foot? There, it is just for 5 marks, so you have to just enumerate. What are the neurological complications? Autonomic neuropathy and peripheral neuropathy. Autonomic neuropathy, what's there? The loss of autonomic, what you say, sensations mostly. So the patient cannot, the symptoms of hypoglycemia will not be recognized by patient's system, or the autonomic response for the hypoglycemia will be absent. Then he will not understand the myocardial ischemia, there will be no pain. So these are the various autonomic resultants of the autonomic neuropathy due to diabetes. So in peripheral neuropathy, mononeuropathy, polyneuropathy, various types of neuropathies are there. Then you can include retinopathy also, but it is more of a what you say, microangiopathy rather than neuropathy. Then you can call secondary vascular cerebrovascular accidents resulting due to micro and macroangiopathy, which can cause neurological complication because of the diabetes mellitus. So how will you treat diabetic foot? This is kind of surgery question. So see, systemic management of the diabetes, nutrition, what you say, anemia, it is one line of management. And second part is management of, what you have to write first is sorry. It's not working. So let it be. So what is it? There you have to write general and special. So what is in general? Improve nutrition, control the hyperglycemia. It is the most important prognostic factor. Then check for the blood supply. How will you check for the blood supply? Because by doing the what you say Doppler, and then checking for the pulsations clinically. So management of the hyperglycemia, then nutrition, then correction of anemia, and say antibiotics. That is one line of management. In case of surgical management, what is there? Ensuring the good blood supply, and then local debridement, then regular dressing, and if the wound is large, and it shows signs of healing, granulation tissue, then skin grafting. Okay. So next question: what are the non-pharmacological management of anxiety? What are non-pharmacological managements of anxiety? These are what you can say behavior therapy is, or what you can call psychotherapy is most important. So what are the what you can say components of psychotherapy or behavior therapy? One is counseling, then flooding the patient with sensory information or the condition which generates anxiety, and flooding the person's sensory system so that he can't react to the situation, or he doesn't feel the anxiety by the situation. Then exposure follow, and then response prevention, means the patient is exposed to the condition which causes anxiety in that patient, and the response is prevented by we can say counseling or giving help, or sometimes drugs also. So these are the various non-pharmacological methods. Next question. An 18-year-old girl presented with itching and oozing over bilateral earlobes over for 2 days duration. History of using artificial earrings was present. History of similar lesion was present at the site of wristwatch. So clear cut, आँख बंद करके, it is contact dermatitis. Most likely diagnosis contact DD. Here the condition is very specific, so DD are slightly different, but you can add atopic dermatitis, irritant contact dermatitis. So these are the few, or sometimes candidiasis also you can add here. Diagnostic test, patch test. How will you manage the patient? What is allergic desensitization? Management, the first and most important thing is remove the irritant which causes the these symptoms, which is causing the symptoms. Then local emollients, antihistamines, or sometimes local steroids. Those are enough. Okay. What is allergic desensitization? Slowly, we are exposing the patient to the increasing doses of allergen, so that his immune system becomes tolerant to the that allergen. That is called as allergic desensitization. Means first a very small dose is exposed so that a person does not show the allergy. Then a slightly higher dose, then more higher dose. That is called as allergic desensitization. So next question. How will you evaluate a case of neonatal jaundice? What is the most common cause of pathological jaundice? So, how will you evaluate a case of neonatal jaundice? Okay, evaluating a case of neonatal jaundice means evaluating the all the steps. See, primary investigations what you will do, checking the blood group of mother and child, or the what you can say RH antagonism, or the RH incompatibility. That is the most important. Then having the peripheral smear of the child done to see any abnormalities in the leukocytes. Then their secondary test, G6PD deficiency, then imaging to see if there is any big hematoma, then checking for the Coombs test to check for the antibodies, and then what are the other things? Checking for hypothyroidism, hyperthyroidism, and other hormonal, or what you can say endocrine problems. These are the steps in what you can say evaluating the case of neonatal jaundice. Okay. So, what is the most common cause of pathological jaundice? Mostly RH isoimmunization, RH incompatibility is a most common cause of pathological jaundice. How will you grade the extent of jaundice? Draw a diagram. The Kramer diagram, starting with phase 4 to 6, 6 to 8, 8 to 12, then 12 to 14, and palms and soles above. We all know it, Kramer's diagram. What are the question 6? What are the complications of pulmonary embolism? What is the gold standard test? Complication: pulmonary infarction, then pulmonary hypertension, right ventricular failure, right ventricular type of cardiac failure, then what you can say, embolism at other places, wasted ventilation. In case of very large emboli, there can be cyanosis also. So respiratory insufficiency we can call. These are the various complications of pulmonary embolism. Gold standard test is D-dimer test. Why D-dimer? Because if there is no D-dimer, there is no embolism. Because D-dimer is a degradation product of the fibrin degradation product. When will fibrin degradation occur? If there is thrombus or if there is thrombus. So presence of D-dimer is the most important test for diagnosing pulmonary embolism. What are the indication and contraindication of ECT? Elaborate the procedure. Indication: schizophrenia, severe psychosis with negative symptoms, violent psychosis, schizophrenia, severe depression, where the patient does not take care of himself, or refractory to the treatment, we can say pharmacological treatment. These are the various indications of electroconvulsive therapy. Okay, contraindications. All the cerebrovascular pathologies we can call, or cerebrocranial pathologies we can call as a contraindication. Raised CSF, previous stroke, severe hypertension, then any tumor. These are the various contraindication of electroconvulsive therapy. Elaborate the procedure. The patient is taken to the ECT room. He is given anesthesia, and then by applying two electrodes to the side of the what you can say temporal bones or lobes, we briefly pass the electric current to induce the convulsions. Briefly describe the principle behind ECT. In what is the principle? Briefly briefly giving the uh, electric current to the patient's brain to induce convulsion. That is the basic principle behind ECT. What happens due to electric current? Few new neuronal pathways are created, and that's why the patient what we can say, can recover through the electroconvulsive therapy. Next question. A 4-month-old child presented with case of high fever, dyspnea, grunting, respiration, nasal flaring, retraction of intercostal spaces. What is the most common pathogen? How will you identify it? Streptococcus pneumoniae. Identify investigations. What are the investigations which you will do? Investigations are what you can say, serology for diagnosing the pathogen and antibodies, and then analysis of sputum. What is the by serology and by microscopy and culture. Okay. Describe the risk factors responsible for the condition. Environmental and individual. Environmental: overcrowding, then damping, then exposure to the pathogen. These are the various environmental factors. Unsanitary conditions. Individual factor: decreased immune condition, malnutrition. These are the individual factors. How will you treat the child if it's already on antibiotics? See, this is the case of severe pneumonia. So if child is already on antibiotics, we have to check which antibiotics he is on, and send the blood for sample for the checking for the what you can say which pathogen is causing pneumonia in this child. And we have to see if the antibiotics are covering both gram positive and gram negative bacteria. If not, we have to add those lacking antibiotic. Then supportive treatment, prevention of contain blood glucose sugar, what you say, blood sugar levels, then electrolyte levels, then what you can say, prevent acidosis, give him supplementary oxygen. This is the treatment line. Okay. Then a 5-year-old boy presented with 3-day. Next question. 5-year-old boy presented with 3-day history of intense itching all over the body, predominantly at night. On examination, excoriated papules were present on abdomen, buttock and axilla. Examination of finger also reveals yes-shaped, blackish threads with papulovesicles at the end. Simple diagnosis है scabies. How will you confirm it? Microscopy and clinically. Explain the variants of the disease. Write about crusted scabies. So, what are the variants of the disease? So, Norwegian scabies or the crusted scabies is what we can call it to it. And others are say the secondary infection, erythroderma can also occur. Crusted scabies, Norwegian scabies, it is in immunocompromised individuals. There is not too many what you can say, the mites are too many and the lesion is extensive, so you have to give aggressive treatment. What are the complications of above condition? How will you treat this complication? Complication for erythroderma can occur, secondary infection, what you can say, pustular, what you can, pustular infection can occur. How will you treat the complication? Antibiotics, not treatment of the existing condition, supplementary treatment. Okay. Question 7. How is dengue transmitted? What are other diseases which are transmitted by Aedes? Dengue by Aedes aegypti. Other diseases, Zika, yellow fever, several other diseases are spread by Aedes. Pathophysiology, dengue shock syndrome. How will you diagnose it? Pathophysiology is leakage of the plasma from the intravascular compartment to the extravascular compartment. So you can call there is a release of some vascular permeability factor, or there is a molecular mimicry between platelets, the antigen of dengue and platelets, and therefore there is a decreased number of platelets and it causes vascular leakage. Then after you have to write this in form of flowchart. Vascular leakage, intravascular compartment to extravascular compartment, and leading to the dengue shock syndrome. How will you diagnose it? Clinically. Then in case of clinically, you can see for signs such as tachycardia, cold peripheries, and a clinical accumulation of fluid in body cavities such as ascites. Investigations, hematocrit, platelet count. Then what is UNV-DCP? How is it? It has elevated dengue in hotspots. NVDCP, National Vector-Borne Disease Control Program. How it is dengue in hotspots? It is PSM question. Just write that it has given. They have acted on multiple prongs of the dengue circulation, such as preventing the generation of mosquitoes, then giving insecticide treated nets, then indoor residual spray for the all 3 stages of the mosquito from larva to the adult mosquito. And after that, what you have to do, because of this annual incidence has come down, and what you can say, we have got a good success in preventing dengue, what you can say, spread. Okay, these are the general points, means just PSM things you have to write here. Then next question B. Write about the national immunization schedule. What is AEFI? Brief about the procedures followed in it. National immunization schedule. वो तो everybody knows. At birth, BCG, HBV, and OPV. Then 6, 10, 14 weeks, Penta, and IPV. And then what you can say, 16, 14 weeks, then 9 months measles, then 15 months booster of DPT, DT especially. Then at between 16 to 14 months, that there is another booster. So we know the immunization. What is the AEFI? Adverse event following immunization. So what are the adverse event following immunization? From acute type 1 hypersensitivity reaction, anaphylaxis, to the delayed reactions such as vaccine-induced disease. So procedures followed in it: anaphylaxis, clinical treatment, acute situation, adrenaline, antihistamines, and supportive treatment. And the most important thing to write here is PSM stuff, which is what are the procedures which are followed in case of AEFI. Document the AEFI, report to the higher authorities, write down the batch number of the vaccine and all the details about the vaccine. Then send the vaccine for checking its if it is a was the vaccine all right or there was any problem with the vaccine, say maybe expired timeline or something like that. Okay. So next question, how will you differentiate atopic eczema from seborrheic dermatitis? So atopic eczema and seborrheic dermatitis, first clinical symptoms, history. What will be different in clinical symptoms? Seborrheic dermatitis has different pattern, such as atopic eczema mostly starts from early age. Then there is what you can say flexural disposition of lesions of in atopic eczema. In seborrheic dermatitis, usually hairs are involved first. Then there is fibrosis at the base of the hairs. Then what you can say, dandruff is one also form of the seborrheic dermatitis. Then history, clinical lesion, age of onset, histopathology. These are the various aspects on which we can differentiate atopic eczema from seborrheic dermatitis. Then how will you treat atopic eczema? Simple. Hydration is most important. Topical emollients, then antihistamines, steroids, oral antihistamines. This is the line of treatment. In case of in severe cases, oral steroid and immunosuppressants. Okay. So question 8: what are the main causes of bilateral pleural effusion? What are the main causes? All the cases where there is a what you can say decreased osmolarity of the blood and there is a increase of water load or fluid load intravascularly. So which are these conditions? Cardiac failure. So there is a fluid overload. Then there is a nephrotic syndrome when there is proteins are less, water is more. Then there is a cirrhosis of liver. These are the conditions where you can say there is a bilateral pleural effusion or hydrothorax which occurs easily. Then other conditions with bilateral infection by Mycobacterium tuberculosis or bilateral pneumonia. These are also few infectious conditions where there can be bilateral pleural effusion. What is chylous pleural effusion? Chylous pleural effusion. The thoracic duct is ruptured and the fluid oozes into the pleural cavity. So the fluid of thoracic duct, which is in which causes pleural effusion, that is the chylous pleural effusion. Then sub-question second, describe the Light's criteria. So what is Light's criteria? Light's criteria contains three subtypes, that is LDH level in the pleural fluid. it should be more than 2/3 of the serum LDH levels. Then the ratio should be more than 0.6 of pleural LDH to the pleural fluid LDH to the serum LDH. And third is protein. Serum protein and sorry, pleural fluid protein to the serum protein ratio should be more than 0.5. So, next question: how will you manage a case of empyema? What are the prognostic determinants? Then, how will you manage a case of empyema? Managing the case of empyema. Then again, a systemic and what you can call a definitive and supportive management. In case of supportive, say hydration, blood glucose, acid, prevention of acidosis. So, and specific, you have to do drain the empyema fluid. If you don't drain, then there is fibrosis and further complication. Then sometimes you have to remove the empyema and the what you call pus, and giving the antibiotic covering the bacteria which are involved. Then in investigations, the analyzing the which type of bacterial investigation for analyzing what is the causative pathogen and giving the antibiotic cover. Then antibiotics can be given in the pleural cavity also to control the infection and empyema. Prognostic determinants: uh, which bacteria is infecting the how much area, or we can call quantity of fluid. Then time since occurrence. Then immunocompetent competent or immunosuppressed individual. Treatment. These are various prognostic determinants. The next question: a 3-year-old male had sudden onset of acute diarrhea for the past 16 days. What is the most common organism involved? Explain the structure of cryptosporidium. It is a persistent diarrhea. It is not chronic diarrhea. It is not acute because it has gone on for more than 14 days. It is a persistent diarrhea now. Most common organism, cryptosporidium. Structure, we all know, means it is slightly odd question, but you can see the structure from microbiology. It is a parasite. Then next, what you can also protozoa. Next, discuss the investigation. How will you manage it? Investigation, mostly stool analysis, stool microscopy, stool culture. Then serological studies for these various organisms such as Cryptosporidium, Giardia, Lamblia, E. coli. Then stool microscopy, stool culture. Then how will you manage the child? If according to the investigation, treat the causative organism, give the treatment, supplementary treatment such as maintenance of hydration, electrolyte, nutrition. What is the diet prescribed for the above condition? In persistent diarrhea, you have type A, B, and C diets. In case of what you can say, persistent diarrhea, this is going on for 16 days, so you will start with the type A diet. What is that? More simple sugars and decreased what you can say lactose products, that is milk. That is the type A diet. If the child doesn't respond to this, then type B, then where there is no what you can say milk, but more simple sugars and protein is supplemented by what you can say chicken or the non-vegetarian diet, what we call it. Then type C diet, very simple sugars and slight proteins. Okay. In question C, what are the essential components of IMNCI strategy? Write about the principles of integrated care. Essential components of IMNCI strategy. It is a kind of general PSM question, that overall improvement of healthcare, improving the capability of the healthcare staff to deliver the care, and third is overall increasing the quality of community healthcare and bettering improvement in the community healthcare practices. These are the essential components of IMNCI strategy. Write about the principles of integrated care. What we do in the IMNCI, those are the principles of integrated care. What are the principles? examine the child, every child for the any danger sign, which we have seen child signs of the dehydration or the pneumonia or fever or many for any danger signs. Then evaluating the child for any nutritional deficiency, immunizational status or malnutrition, what we can call nutritional status. That is the first analysis. Then categorizing the illness, treating the child, then referral in case of warning signs, then counseling of the parents. Those are the principles of integrated care. Okay. Describe briefly about IMNCA case management process. What are the advantages and disadvantages of IMNCA? Case management process, what are the things in that? Simple things. First, analyze the child for any, what we have said above, the principles. Analyze the child for any danger signs, nutritional status, immunization status, treat the existing condition, refer for if there are warning signs, and counsel the what's what we say, parents. Then advantages, multiple diseases are screened, the ground level staff or the what we can call the first contact staff such as ASHA, ANM workers can screen the child, then effective early treatment, then complete analysis of nutritional immunizational status, then preventing child mortality, improving the overall health of the child. Disadvantages, not many, but we can call this as sometimes delay occurs in case of first point of contact. Then sometimes misdiagnosis can occur. The staff may not be adequately trained. These are the various disadvantages. Okay, so that's it. Remember, in case of medicine, surgery, pediatrics, or the especially paper 2, divide your diagnosis, your differential diagnosis or investigations into the regular or routine, and then specific and treatment also. Okay, so it will give better marking to you. Okay, so thanks everybody for listening, and we are done with this paper. Okay.